Osteoarthritis. It is derived from the words osteo, which means bone, arth, which means joint, and itis, that means inflammation. The itis of osteoarthritis could be considered misleading as inflammation is not a conspicuous feature. Some clinicians refer to this condition as osteoarthrosis to signify the lack of inflammatory response, so it could be osteo, arth, and osis, that means abnormal condition, instead of itis due to absence of inflammation. It is also known as OA, osteoarthrosis, and degenerative joint disease. It is a chronic progressive degenerative disease and the most common form of joint disease, and a condition of synovial joints, especially the big weight-bearing joints of the body such as hips, knee, vertebrae, interphalangeal joints of the fingers, etc. It is characterized by focal loss of articular hyaline cartilage. In normal spine, the intervertebral disc size is normal between two vertebrae, while in osteoarthritic spine, bone spur, also known as osteophytes, are formed, that are the bony projections that develop along the bone edges that leads to narrowing of the intervertebral disc. Etiology. The age of patient is usually above 60 years, mainly in the aged individuals. Heredity. Twin and family studies shows that genetic factors play a major role. Osteoarthritis is more common in women, except at the hip where men are equally affected. Abnormal stress and strain of joint, obesity, and endocrinopathy or acromegaly, that is a hormonal disorder that develops when pituitary gland produces excess of growth hormone. Predisposing factors. These are trauma and repetitive adverse loading of joints during occupation or the sports, such as in farmers, hip is affected, in minors and professional footballers, knee suffers, in ballet dancers, osteoarthritis of toes is present, while in karate, fingers are affected. Pathogenesis. The molecular mechanism of damage to cartilage in osteoarthritis appeared to be the breakdown of collagen type 2, probably the interleukin 1, tumor necrosis factor, and nitric oxide. Pathological changes. The pathological changes occur in the articular cartilages, the adjacent bones, and synovium. Pathological changes in articular cartilages. Initially, there is loss of cartilaginous matrix or proteoglycans. Further progression of the process causes loosening, flaking, and fisting of the articular cartilage, resulting in breaking off of pieces of cartilage, exposing subchondral bone, that is a layer of bone just below the cartilage in a joint. Radiologically, the progressive loss of cartilage is apparent as narrowed joint space. Pathological changes in bone. The denuded subchondral bone appears like polished ivory due to friction between the bones, due to death of superficial osteocytes and increased osteoclastic activity, causing rarefaction, that is decrease in density of bone, microcyst formation due to osteonecrosis, and occasionally microfractures of subjacent bone. These changes result in remodeling of bone and changes in the shape of the joint surface. leading to flattening and mushroom-like appearance of the articular end of the bone. The margins of the joint respond to cartilage damage by osteophyte or spur formation. These are cartilaginous outgrowth at the joint margin which later get ossified. Osteophytes give the appearance of lipping of the affected joint due to overgrowth of the bone around the joint. Loosened and fragmented osteophytes may form free joint mice or loose bodies. These are the loose fragments of joint of bone, cartilage, or both floating inside the synovial fluid. So the joint mice will be present in the synovial fluid. Pathological changes in synovium. Initially, there are no pathological changes in the synovium, but in advanced cases, there is low-grade chronic synovitis and villus hypertrophy. There may be some amount of synovial effusion associated with chronic synovitis. Types. Osteoarthritis may be primary or secondary. Primary osteoarthritis may be caused in patients having cervical spondylosis affecting cervical spine or lumbar spondylosis affecting lumbar spine, while in secondary type is a sequela to various conditions like trauma, gout, rheumatoid arthritis, hyperparathyroidism, diabetes, Paget's disease, acromegaly, Wilson's disease, etc. Clinical features. The joint pain would be, its onset is insidious, it takes time over months or years, variable or intermittent nature over time with good days and bad days. Mainly related to movement and weight bearing, relieved by rest. Only brief less than 15 minutes morning stiffness and brief less than 5 minutes gelling or stiffness after rest. Usually only one or a few joints painful. Joints affected. The weight bearing joints are affected like hip joint, knee joint, vertebrae, and interphalangeal joints of the fingers. Other clinical signs are joint line or periarticular tenderness, muscle weakness or wasting of muscle. Sometimes there may be troublesome nocturnal pain disturbing the night sleep. No or only mild synovitis causing effusion, causing popliteal cyst or Baker's cyst, a fluid-filled cyst that causes a bulge and a feeling of tightness behind the knee in popliteal fossa. Bony swelling or osteophyte around the joint margins. Healthy joint with normal bone surface. An osteoarthritic joint with hypertrophy and spurring, that is formation of a spur or osteophyte and erosion of articular cartilage. Crepitus, palpable, sometimes audible, coarse, crepitus, that is audible, grinding noise due to rough articular surfaces. Gradually, as the pain increases, patient tends to restrict the movement of the joint, which becomes stiff due to muscle spasm, fibrosis of the capsule, formation of osteophytes, and fear of pain. Nodal osteoarthritis. Typically, each joint goes through a phase of episodic symptoms for 1 to 5 years, while the node evolves and osteoarthritis develops in the underlying interphalangeal joints. Affected interphalangeal joints often show characteristic lateral deviation, reflecting the asymmetric focal cartilage loss of osteoarthritis. It has a very strong genetic predisposition. The daughter of an affected mother having approximately a 1 in 3 chance of developing nodal osteoarthritis. Formation of nodes. Pain, stiffness, and swelling of one or a few finger interphalangeal joints. Gradually over many months, more finger interphalangeal joints, more common in distal than proximal, are affected. These joints develop posterolateral swellings on each side of the extensor tendon. It slowly enlarges and hardens to become the nodes. In distal or terminal interphalangeal joints of the hands, the formed nodes are called Heberden nodes, while the nodes formed in proximal interphalangeal joints are called Bouchard's nodes. There is a mnemonic on nodes, that is HDBP, where H stands for Heberden nodes, D for distal interphalangeal joint or DIP, means Heberden nodes occur in DIP joints, while B stands for Bouchard's node and P for PIP, that is proximal interphalangeal joint, means Bouchard's node occur in PIP joints. Heberden nodes in distal or terminal interphalangeal joints of the hands, Bouchard's nodes in proximal interphalangeal joints, and carpo, metacarpal or CMC joint is also affected, causing thumb base squaring, giving an appearance of a square hand configuration. Involvement of first carpometacarpal joint with marked osteophyte and subluxation or partial dislocation leads to thumb base squaring. The base of the thumb looks like a square. Another appearance is gulving appearance. It is an X-ray sign of the fingers in interphalangeal joints with a typical gulving appearance, means it appears like wing of seagull or seabird in case of erosive arthritis. In osteoarthritis of hip, the weight-bearing superior femoral pole is very commonly affected. Also, medial side is involved. The middle compartment of a medial tibiofemoral joint is often involved, and genu varum or bow-legged deformity results. Investigations. Blood examination shows normal ESR. Test for the rheumatoid factor is negative. C-reactive protein and anti-nuclear antibody tests are negative. X-ray signs. There is a mnemonic of X-ray signs of osteoarthritis. It is LOSS, LOSS, where L stands for loss of joint space, O for osteophytes, S for subchondral sclerosis, and another S stands for subchondral cyst. MRI. MRI shows early cartilage and subchondral bony changes. Arthroscopy reveals cartilage fissuring and erosion. Synovial fluid shows presence of calcification. If there is a pyrophosphate deposition, the calcification is linear, and if hydroxyapatite crystals are deposited, it becomes spotty. Management. During acute stage, rest is essential. Diet should be so adjusted that it helps reduction of overweight. Unusual strenuous joint movements must be avoided. Occupation may be changed if required, and physiotherapy may be required as per the need of the patient. Thank you for your time.